Hello, everybody, and thank you for joining us today. Today, we will be addressing health disparities for LGBTQIA plus people and people with HIV in public housing. In today's session, we will focus on stories from the field. This webinar is brought to you by the National Center for Health in Public Housing and is also a collaboration with the Fenway Health Institute. This is just a kind reminder to everybody that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or any comments or any promising practices that you would like to share with us today in relation to today's topic. Please raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and the recording link will be sent to you via email after today's session. And also, just to have an idea of who is joining us today, we would want to ask the audience if you would like to provide your name, what organization you're joining us from, and your title of that organization. Before we continue, this is some background information about the National Center for Health in Public Housing. The mission of NCHPH is to strengthen the capacity of federally funded public housing primary care grantees and other health center grantees by providing a range of training and technical assistance. The information of today is only from the author. Thank you so much. And also, this is just a brief introduction about myself. My name is Filipina Sandoval, and I am the TTA manager of NCHPH. I will help facilitate today's webinar. And we also have with us Dr. Jose Leon, who is our Chief Medical Officer, who will be providing some background information about residents living in public housing. Today, we also have our guest speakers, Dr. Jamie Barney, who is the Vice President of Behavioral Health at Open Health. Then we will also hear from Anthony Fortenberry, who is the Deputy Executive Director at Callan Lord. And lastly, we also have Ms. Margot Prelo, who is the Clinical Director at Harlem United. So here's some background information also about the health centers that are close to public housing. There are over 1,300 federally qualified health centers that serve to 30.5 million patients. In 2022, there were also 483 FQHCs that were in or immediately accessible to public housing that served to 6.1 million patients, and 107 public housing primary care grantees that served to over 900,000 patients, according to 2022 UDS data. And this is also some additional information about public housing demographics. According to HUD 2023 data, there were 1.5 million residents that serve 1.5 million residents with 2 persons per household. 52% were white, 43% were African American, 26% were Latinx, 19% were elderly, 36% were children, with 32% that were female-headed households with children. And now I will pass it on to Dr. Jose Leon, who will continue with today's presentation.
Thank you, Fide, and hello, everyone. We are going to host the third webinar of this HIV series. If you have participated in the first 2 activities, you might be familiar with these slides, but this is just a comparison between all community health centers and those health centers located in or immediately accessible to public housing, and the number of patients who were diagnosed with HIV in 2022. Next slide, please. All health centers are required to provide linkage to care once a patient has been diagnosed with HIV. And in 2022, the percentage of patients who were linked to care after being diagnosed with HIV was over 82%. Next slide, please. in regards to the quality of care measures, one of the measures that health centers need to provide to HRSA through the UDS Uniform Data System is the estimated percentage of patients who are being tested for HIV. And in the same year, around 44% of patients were tested for HIV. Next slide, please. We are helping and we are supporting the ending the HIV epidemic by 2030. And as you know, the outcome of what we're trying to achieve is that by 2027, 75% to reduce the new HIV infection by 75% in 2025, and by 90% in 2030. Next slide, please. In regards to sexual orientation data, these are the percentage of patients who provided the sexual orientation. These patients were patients attended by public housing primary care grantees. As Fide mentioned, we have around 107 health centers located or providing services to this population, and about 390 health centers reporting that they are in or immediately accessible to public housing. Next slide, please. And the gender identity data as well. This is the gender identity data provided by all patients who are public housing primary care grantees. And this is reported through the electronic health records of the health centers. And this is the latest data that we have available. And this data was captured is capturing the 2022 numbers. Next slide, please. And I am happy and very honored to have Dr. Jamie Barney, who is going to take it from here. Hello, Jamie.
Hi, good morning. I am with Open Healthcare Clinic, and I am very excited to speak with you about the services that we provide, specifically with our patients living with HIV and the housing programs and other services that we have tailored to persons living with HIV and all of the different subpopulations that encompass. Next slide. So, Open Healthcare Clinic was founded as HIV/AIDS Alliance for Region 2 in Baton Rouge. We started over 28 years ago, and one of the first programs with direct service provision was our housing programs that started in 2001. Some of our HUD funded housing. We opened a full service medical clinic after that, and then we obtained FQHC status in 2015. If you look at the map, you can see the little red star. That's where we are in Louisiana, the South, the deep South. Next slide. So these are some of the services that we provide. We try to do a comprehensive approach. Our tagline is whole care for the whole community. So we offer comprehensive medical and support services to all community members as a FQHC. So there's not anyone not eligible to access services here. We provide services to everyone in the community. According to our 2022 UDS, which goes over all of the patients that we see. 63% of our patients were below 100% of the federal poverty level, and 85% of our total patients were below 200% of the federal poverty level. Less than 5% were unknown and 9% above 200%. And 44% of our patients had Medicaid and 36% of our patients were uninsured. So we are working with persons who face a lot of barriers to accessing healthcare and resources that they need. Next slide. So this goes into the population of patients we work with living with HIV. So according to the Louisiana HIV/AIDS and Early Syphilis Surveillance Report, the quarterly report that is produced by the Louisiana Department of Health, Office of Public Health, as of June 2023, there were a little over 5,000 persons living with HIV in the Baton Rouge metropolitan statistical area. And the Baton Rouge MSA ranked 5th nationally for HIV case rates. During the calendar year of 2022, there were a little less than 900 persons newly diagnosed with HIV in Louisiana, and almost 20% of those persons lived in the Baton Rouge MSA. And if you look at the little circle chart that shows persons living with HIV in Metro Baton Rouge, approximately half of those persons also have an AIDS diagnosis, which indicates to us that people are either finding out their diagnosis late or they're not able to consistently stay in care. So we still have a lot of work to do. We've been providing persons living with HIV in the Baton Rouge community services for over 28 years. And during the calendar year 2022, we serviced 972 persons living with HIV. And that is approximately, if you were to just look at the numbers, about 18% of the population of persons living with HIV in the Baton Rouge metropolitan statistical area. Next slide. So the populations we work with have a significant number of disparities in HIV diagnosis and access to care. So that includes the groups listed below, so LGBTQIA+, people of color, persons with mental health and substance use disorder, persons with no or low income, and persons experiencing homelessness. So according to our UDS, similar to the information we just reviewed, 9% of our patients identified as lesbian are gay or bisexual. 3.2% reported either other from the categories that were listed, that they didn't know, chose not to disclose, or the information was unknown. And in regards to gender identity, there were 26 of our patients that identified as a transgender male, transgender man, or transmasculine, and 57% identified as transgender woman, transgender female, or trans feminine. So the next slide, please. So those disparities are further exacerbated when we're working with the persons living with HIV. From the same report from the Office of Public Health in Louisiana, the primary risk factor for new diagnosis of HIV in Louisiana is gay, bisexual, and other men who have sex with men. In 2022, 60% of those persons who were diagnosed listed that they were a gay or bisexual male. And an additional 2% reported being gay or bisexual and also injecting drugs, which are the risk factors that they assess for when doing the testing for persons living with HIV. Next slide, please. Those so of course persons, the subpopulations we're identifying, they're more vulnerable because of the stigma and discrimination they face. That is further expounded for persons living with HIV because there's a multitude of additional barriers specifically related to stigma. And so here in Louisiana, we still have HIV criminalization laws that don't necessarily coincide with science. And then we still have a sex offender, like they're forced to register as sex offender and sex offenders. And the status of sex offense here, of course, when people hear that, the stigma of that is child molester. There's shelters here still that do not allow persons living with HIV a part of the screening for getting emergency shelter in even if there's a hurricane, they're going to ask specifically, do you have HIV? And if you say yes, you cannot access that shelter. And there's only 3 shelters in this area. So you're completely wiped out of one just on screening. There's still discrimination in housing and employment. There's ostracism. Of course, we have patients who are asked not to come back to church. Friends stop speaking with them, families disconnect, don't invite them for holidays anymore. And then there's the internalized guilt and shame that comes with it. Of course, a lot of it may be external, but then when you're getting those messages, some of it plays in the internal for a lot of our patients. So we'll see some explosions of emotion, and we have to make sure we're keeping in mind everything they're dealing with, and use a trauma-informed care model when we're working with patients, and giving some grace and trying to create a system where we recognize that our patients are dealing with a lot, and we need to be a little more caring and gracious from the moment they come in the door, and not do anything to re-traumatize them or further traumatize them. Next slide, please. So, of course, I wanted to just mention the intersectionality with all of this, because we're talking about, different subpopulations, and I just want to make sure I'm clear with expressing that when we're trying to work, especially when we're trying to work with patients dealing with internalized guilt and shame, we have to be careful in recognizing how our systems play a major role in oppression. And that's more so with persons who have multiple identity categories that experience discrimination. So we're talking about persons of the LGBTQIA plus community, persons of color, and that's our Black and Latina patients, and our Latinx patients, I'm sorry, persons with substance use disorder, mental health disorder, disabilities, homelessness, and low socioeconomic status. A lot of times this is still the same person, and they're dealing with all those different things all at once. And so with the intersectionality, that's more so of how these systems overlap to create distinct experiences for persons with multiple identity categories. And so while we do have some best practices in working with this group, that group, this group, that group, we got to make sure we're looking at this one individual and treating everything that person is dealing with. Next slide. And so the social determinants of health piece, we've been hearing a lot about this, and it is very important, but this includes those non-medical factors that do have a significant influence on health outcomes. And these are the conditions where people are born, where they grow, where they live, where they work, and how they age, and how all of those things come into play as well here. Next slide. And so I found this chart by Kaiser Family Foundation. I thought it was great. It encompassed a lot of those different things with examples, and how all of those things influence the overall health and well-being of persons. And so an example of what this looks like with our patients that we see, we'll have, like with transportation, for instance, public transportation in Baton Rouge, the very earliest starts at 5:24, and that's only one of the bus routes. For the most part, they start around 6:30, closer to 7 o'clock. And then they stop at 9:27 at the absolute latest. And so you may have to ambulate several miles just to get to the bus stop from your home or your destination. You're going to need multiple transfers. So it's not like you come out at 5:24 and you're going straight where you need to go. So you're probably going to be waiting at different bus stops, waiting at different transfers. So a destination within a city, which may take 15, 20 minutes by car, is going to take probably several hours both ways. And then our bus system only operates in the city of Baton Rouge, so not the entire MSA. So all the neighboring towns and communities, the only options for transportation, if you don't have a personal vehicle, are cabs and ride shares, which of course is going to get much more expensive. But that also is putting limitations with jobs, with housing, with schooling, all directly tied to just transportation. So in certain communities where Christmas is coming, you can say, okay, I have a teenager, they can get a quick job at the mall. That's not an option. because there won't be time if they're getting off from the mall at 9 o'clock, there's no way to get home. Like you would have to get off by 5, 6 o'clock to guarantee transportation home because no one in the house can help. So all of these things directly impact our patients' ability to move around where they live, where they work, and where they're able to socialize and with others. Next slide, please. So we're at Open Health, in homage to our origins, and then also to make sure we're clear what services we provide specifically to persons living with HIV. One of our service lines is Open Health Heart. This branding was intentional. So with Open Health, it helped reduce the stigma associated with the name of our organization having HIV involved in the name. And now as a FQHC, since we're servicing everyone in the community, our patients don't have to worry about unintentional disclosures just because they're in our parking lot, which previously was an issue. So all of our staff, all ID badges look the same, even if you're under Heart. When we're making payments for rental assistance and housing, nothing indicates anything about HIV. Even when persons call in and ask how you can be eligible for certain services, we're very careful in screening and letting people know what they're eligible for, so we avoid unintentional disclosures. But we offer testing and treatment. We have a rapid start model where our patients are not only getting medication within I think 72 hours is what they try to do, but they're taking their first dose before they leave the office. We have case management services, patient navigation, housing, employment services, primary medical care, behavioral health care, and oral health care services. And then we also have a robust PrEP and PEP program that we're very proud of, and at-home testing kits that we just rolled out. So that's been exciting to see how that works out. Next slide. Now, specifically with housing, we have a HOPWA grant, housing opportunity for persons with AIDS, that is a federal grant that passes through the city of Baton Rouge for us. So depending on the year, because with modernization, we're being heavily impacted, so our housing program has been scaling down, unfortunately. But we currently still provide what we used to call project-based housing, but now we're kind of calling it facility-based housing. But same thing is, we own an apartment complex and 6 standalone houses at scattered sites in the Baton Rouge area. We provide STRUMU, so short-term rent, mortgage, and utility assistance. We previously had tenant-based housing where we're providing rental assistance to other properties, and permanent housing placement, which is a first month rent and deposit to help persons establish safe and stable housing. We also have 2 continuum of care grants. One is specifically for people living with HIV, that's the subpopulation. So let me back up a little bit. The continuum of care program targets persons who are literally homeless and the persons who have a disability. And by HUD's definition, HIV is a disability. So we have one group who's our subpopulation. While we're focusing on people who are homeless, our subpopulation is people living with HIV. And then we have another COC grant where our subpopulation is a dual diagnosis of persons living with HIV, persons who have a substance use disorder and or mental health disorder. So 2 of the 3. And that is just permanent supportive housing offered through that program. And we have a housing first model, so low barrier for entry. We're going to not only do everything we can to help prove eligibility, like with the homelessness. So we are going out talking to people and getting firsthand documentation of certified homelessness. But we also are going to assist, like we need social security cards for everyone in the house. So we're going to approve you for housing. We're going to get your letter. We're going to start looking for somewhere to stay, but then we will transport you to the social security office and sit there with you to get the cards. We're not going to deny you access because you can't figure out how to navigate these systems independently. Next slide. See, trying to keep up with time. Okay. So we have case management services. So we have funding for case management through our Ryan White grants, which we usually just kind of lump up together. But we have some Ryan White funds, Minority AIDS Initiative funds, and ending the HIV epidemic funds that allow us to provide case management services. And then we have case management with our HOPWA program and our 2COC programs. And so generally speaking, case management is going to consist of assessments, assessing the patient's current situation, working with the patient to come up with the case plan for stable housing, for viral load suppression, and other goals that the patient identifies, and removing any barriers and connecting the patients to resources, whether internally and externally. Next slide. Additionally, we provide behavioral health services. So we have the individual and group counseling. We have medication management on site, support groups, and then our behavioral health team is very involved in our consumer advisory boards and keeping those afloat. And then we offer crisis intervention with our medical teams, case managers. But we try to keep a behavioral health counselor at each of our sites so they're able to go and respond if there's a person in crisis. Specifically, also when persons are first diagnosed, they may need, crisis intervention services, which we have always provided. Next slide, please. And I'm sorry, can you click again? I think there's some more information on the left. I didn't do that on purpose, guys. I'm sorry. So we have, so with our grant funded services, specifically with people living with HIV, we have outpatient ambulatory, which is the medical care. We have funds for oral health care. We have patient navigation, which is what we call our peer advocates. So our persons living with HIV who offer support when persons are first diagnosed in those first couple of months when they're getting adjusted to the system of care. We have an employment coordinator who does job training and readiness and directly connects persons to employment. That's funded by our HOPWA program. With our EHE initiative, we are able to help with identification cards and birth certificates, which are things our patients need to access other things like employment, school maybe. We actually use some EHE funding to launch a Navion app, which is an app we use with persons. We developed it. There's videos with our staff, like our counselors and peer advocates, our patient navigators explaining different processes. There's little infographics explaining how medication works and what viral load suppression is. And so our patients are able to also get an incentive if they look at certain videos they're assigned when they're first start in the care. So they'll get it's $25 and $50 increments for doing certain things. And so that way they're playing the videos and they also get a little extra money, which never hurts anyone. We have an emergency financial assistance with our Ryan White grant. So that allows us, and our COC grants as well, and some HOPWA funds were able to do this, but to pay for some emergency medications, utility assistance, food vouchers. We do grocery delivery as well. We have rental assistance with our Ryan White program. We help with transportation in the form of gas cards and ride shares. And then we also are the recipient of the state grant for part Ryan White Part B, which is the cost shares and premiums for the entire state of Louisiana, all persons living with HIV. Next slide. Oh, and that's just a little bit about Navion that I mentioned, the app. Okay, so these are some things that all happened within the last, I want to say 5 years or so, maybe 10 years. And it just shows how it's still very dangerous for our patients who are experiencing homelessness. So the person all the way to the left, he just decided to start murdering persons who were experiencing homelessness. We had like a little serial killer, and initially no one was really alarmed because, of course, the persons who were being targeted are those persons who are most vulnerable to that type of thing. So it doesn't usually pick up a lot of steam, but it was a serial killer, and three persons unfortunately lost their lives just because they were not sleeping indoors. We had another person recently there, it was in the news, who was homeless, and he was just trying to travel to get to his family, and the exposure he passed. And then last year, for some reason, a local store clerk decided to throw water on a homeless woman during freezing weather, and that went viral at that time. But it just shows like the heartlessness and how people will treat persons just because they're outside, like they aren't important. But we do a lot of work to try to help with those things and combat homelessness in general, because again, it is very dangerous. So we had one example I wanted to share as a case study, was a patient who benefited from case management, Ryan White case management and employment services. So this patient was released from incarceration after 12 years, and with working with the employment coordinator, we had secured employment within 30 days. This patient was a trans woman, and so there was actually some delay related to discrimination based on that. And so the patient was able to get promoted within 6 months. And we had an event where we spoke to, we had other organizations come in and talk about employment in the community. That patient actually came and spoke and was crying, talking about how she had just purchased her first vehicle on her own, and how life, like they just never thought they would be in a position where they would be able to celebrate something like this after being in prison for so long. And the other one I wanted to mention, we had a young woman in her early 20s, and her 4-year-old son were living in a furniture store. She was not virally suppressed. The child was not getting any education because they were just surviving. So she was approved to get into our COC housing program. After that, she was able to secure housing. We had some issues because she was helping other persons who were still homeless, and she was evicted. But we did some counseling. We were able to work through that. We got her rehoused, and now she's doing much better. She's virally suppressed, and a child is enrolled in school and has been consistently since then. And those are ways we measure success. Like our patients don't have to run for president for it to be successful. These are people who are not homeless. They're employed. They're happy, and they're breaking barriers they didn't think they would be able to break. And that is what we're here to do. Next slide, please. This is my last slide. And so so we work with vulnerable subpopulations. I would say our best practices are, one is being clear that one size does not fit all. So we want to make sure we're careful about not stigmatizing any particular service, especially with mental health. If something like counseling may not have worked for you, maybe it was the counselor, maybe it was you, but it may be beneficial for someone else. So we want to be careful about saying, well, we tried that during this year with this group and it didn't work, right? So the main thing is respect, dignity, and care, no matter who walks through that doors. That is what we're going to champion. We're going to prioritize patient needs because you are not an authority on anyone else's life. Peer models have been very effective when someone can sit down and say, I've been where you are, and I know how, I know what you may be feeling. I have an idea of what you may be going through. And representation matters. So hearing the voices of the persons receiving services, hearing from them what they need and how they need it, and then making sure we're using evidence-based practice and continuous quality improvement. So even those things we're doing well, we are still going to implement quality improvement initiatives to do even better. And so that is it for me. Thank you very much. And whenever the time allows, I'll be happy to answer any questions anyone may have.
Thank you, Jamie. Thank you so much. This was a great presentation, and thank you for everything you do for your patients. And now we are going to hear from Anthony from Colin Lord, and he has a very interactive session. So please engage in the chat. If you want to ask a question verbally, your line also can be unmuted. So Anthony, take it away.
Thank you so much. And thank you, Jamie. That was a fantastic presentation. I have just a few slides and really was hoping to have a much more interactive discussion. So again, as was said, please put some questions in the chat. We can go into the next slide. Just to tell you a little bit about Callan Lord Community Health Center by the numbers. We care for over 18,000 patients. We have 4 sites in 3 boroughs in New York City. Importantly, about a third of our patient population identifies as transgender, gender diverse. And we also, I think, interestingly, skew pretty young. You can see there over 35% of our patients are between the age of 25 and 34. Next slide, please. So just some objectives about the conversation today. Really wanted to discuss kind of high-level strategies of how we are aiming at Callan Lord to address disparities that exist among our populations. And as Jamie mentioned, really with a focus on intersectionality, because we do kind of establish these best practice in for certain populations, as an example for youth, but many of our youth that we care for are transgender or gender diverse, and so really kind of layering in or come from communities of color, and so kind of layering in all of those different identities to ensure we're providing as comprehensive a healthcare model as possible. Next slide. If you joined last week, I went into a deeper dive in some data for LGBTQ+ stigma and discrimination, but just, again, to review, why we want to implement some strategies to address issues that are specifically impacting this community. We know this community has decreased access to health insurance, employment, housing, retirement benefits, adoption, of course. More than 1 in 10 LGBTQ Americans report experiencing discrimination from a healthcare provider. This results in 15% of people reporting postponing or avoiding medical treatment, and up to 20% specifically avoiding primary care due to experiences of discrimination. In addition, there's a shortage of healthcare providers who are knowledgeable and clinically competent in LGBTQ health. And of course, as most people are likely aware, there's been a wave very recently of anti-LGBTQ+ legislation. 84 of these have been passed into law, and of these anti-LGBTQ+ bills, 136 are focused on healthcare restrictions. I believe we're up to over 500 proposed laws. Of those, 136 are focused on healthcare restrictions. So this is the environment in which LGBTQ+ patients are engaging in the healthcare services. Next slide. So what disparities are caused by that stigma and discrimination? We see that LGBTQ Americans experience disproportionate mental health issues and limited access to culturally competent mental health providers. LGBTQ youth are 2 to 3 times more likely to attempt suicide and more likely to be homeless when compared to their cisgender and heterosexual counterparts. Many who have sex with men experience higher rates of HIV and other STDs. This is especially true among communities of color. There's disproportionate impact there. And LGBTQ populations have higher rates of substance use, alcohol use, tobacco use, alcohol use, and illicit substance use. And finally, older LGBTQ adults face additional barriers to health because of isolation and a lack of social services and culturally competent providers. These are just a handful of disparities. And as I said last week, I kind of went into a deeper dive. I'm sure those slides are still available. Next slide, please. So what are we doing about these the healthcare disparities and the impact of stigma and discrimination in the community? First and foremost, and as Jamie had mentioned, really centering patients and centering patient voices in the interventions that we implement. So I'm going to talk a little bit about our community advisory board and how the CAB informs our internal practices. Certainly a needs assessment, both within your patient population, but also within the community and importantly within staff, to see how you can better prepare the staff to address the needs that patients are identifying. of course, doing that through training and education, competency evaluation. And then finally, I'll talk a little bit about expanding access to support outside of the clinic walls. Next slide, please. So centering patients, we have a really, if you joined last week, you met one of our community advisory board members, Stephen, who has been a longtime patient and advocate, and has partnered with the organization to be very vocal in how we iterate our grant funding, how we iterate our programs and services, and importantly, how we iterate our quality, continuous quality improvement around those services. So as you see here, these are all of our partner committees. And what's important in the infrastructure that we've created around our CABs is that each of these CAB committees has an internal operations committee counterpart. So as an example, our HIV committee and the CAB has a counterpart within the organization. We have what we call an HIV operations meeting or our HIV ops meeting. And a member of the CAB, a CAB representative, patient representative, will be invited to that meeting on a routine basis to provide feedback around new programs and services. And so as a concrete example, when we initiated our Rapid Start, our rapid treatment program, we engaged the CAB to provide feedback on how we can best communicate this change to patients and ensure that we were providing health education to patients that had questions about this new practice. Importantly, I met Stephen last week. He mentioned the alumni committee, which he founded. This is, for our CAB, we really want to engage new voices. And so we encourage people to, take a break from the CAB or join a different partner committee so that we can, have an evolution of voices over time. Stephen came up with a great idea to create an alumni committee that is kind of a resource and historical knowledge for the CAB. And is very, very engaged in a lot of our patient-facing activities. And finally, our quality committee, the CAB is really involved there. We have, of course, our internal quality committee that has CAB representation. So anytime we're implementing a quality improvement initiative, we utilize input from our patients on how they will experience that intervention and any recommendations for improvement. Next slide. This is just a very high level for our needs assessment. Of course, we do our patient satisfaction surveys, but importantly, we do what we call our pulse checks, or our kind of a quick, just several questions at the front desk, kind of a survey around certain quality initiatives. We also do this with our staff whenever we're looking for kind of a change management evaluation of success. I think it's a really great way in which to get kind of just check the pulse of both patients and staff around the kinds of interventions that we implement. Certainly, I think looking at social drivers of health and exposure or potential risk for patients in any of the subcategories that we talked about, whether it is evaluation of HIV prevention or treatment efforts, its specific quality improvement efforts. We really, in our quality management plan, we might see that we're doing a great job with mammography, and we might be meeting our targets, but we do what we call a health equity analysis on all of our quality metrics to say, so for all of these subpopulations for which there are known historical disparities, how are we doing with those groups? And so, we might find that for mammography, our trans male population is not engaging in mammography services. And so we might go to the CAB and ask for advice around, how we might iterate services that are more targeted or increase health education that is more targeted toward those populations that are experiencing disparities in our quality metrics. And that, of course, ties into the clinical quality outcomes. The only piece I wanted to mention here was the importance of data transparency. And so really working with individual medical providers to give feedback on how well their patient panels are achieving these quality metrics and addressing healthcare disparities that have been identified organization-wide. Because you might find that, you're just really having a hard time moving the needle on a certain quality metric. And it's just a handful of patients at one of our sites, a handful of medical providers at one of our sites that may not be documenting their intervention appropriately, that's causing, a disparity more in data than clinical care. And so kind of doing a deeper dive into these disparities using clinical data. Next slide, and I promise I'm almost done, so we can turn this over to you, Margot. For our training and education, we have clinical directors in each of the, I mentioned we had HIV ops, we have our trans health ops, we have our women's health ops. Each of those has a clinical champion that really helps to drive innovation around interventions. We also use a team-based strategy so that it is really dependent upon the care team to address the healthcare disparities that we're identifying. And so it's not just a medical provider's responsibility to ensure that we are, doing SBIRT as an example. We train nursing staff, we train our addictions counselors, and really using an interprofessional approach, not only in the training, but also in the competency assessment and evaluation of success. So the accountability is on the care team to really have a shared responsibility for achieving the health outcomes for patients that we've identified as having additional needs. We also use a top-up scope strategy, so ensuring everyone is only doing the work that is required by or expected from their licensure. So, if an MA can do something appropriately, we are driving decision-making down and driving responsibilities down so that really our medical providers are only doing that work with their license that is required by their licensure. And I already mentioned the competency evaluation and data transparency. So next slide. All right, this is the last thing I'll mention is just community access. You can see all of these things here. Jamie already also mentioned a lot of this. It's so our patients have not only intersecting identities and disparities as a result of those identities and needs, but they also need us outside of our clinic hours. And so really working with external organizations and community-based organizations to provide those additional services. Home-based programming is, I think, another really important component that has ramped up since COVID, and ensuring that we're able to address disparities in between medical visits. And this last slide is just some references and resources that you can take a look at. And also my contact information is available there as well in the next two slides. Those are your resources. The final slide is my contact. Please feel free to reach out if you have any questions. And with that, I will turn it over to you, Margot.
Good afternoon, everyone. My name is Margot Prelo. I'm the managing clinical director for Harlem United ADHD program. I was telling the panel that this is my first panel, so bear with me. I want to give you an overall of the history of Harlem United. In 1988, at the height of the initial wave of the HIV epidemic, the Upper Room AIDS Ministry was founded in response to the community cries for help. Located first in the basement of a church, URAM provided the very basic needs for those most affected by the epidemic. In addition to AIDS, the community served by URAM was one disproportionately affected by homelessness, mental health needs, and substance use disorders. Founded to address the lack of response for the established providers, URAM responded to the unique personal, social, and institutional barriers faced by the community is served by first offering two core programs, 60 units of supported housing based on scatter site model and a social daycare center. These two programs were only a start to address all the complex needs of our persons. I'm gonna take your word, Jamie. I like that word. Each new program at the URAM added was identified based solely on the needs of our clients. In 1991, URAM began its first housing program with government HRA funded dollars. In 1993, the URAM board and management began pursuing an adult day healthcare program, which I am in charge of. Licensure, which would extend medical interventions to let me slow down. disenfranchised clients. This was a bold move as other agencies had passed on this opportunity, and it would prove to be successful. In 1995, the organization was renamed to Harlem United Community Aid Center, Inc., to reflect the inclusion of anyone in need. Between 2000 and 2003, our ADHC became the first in New York to offer primary medical care, dental care, and a full continuum of mental health services. In 2001, we became a founding member / owner of AmitaCare, then VitaCare. The only Medicaid special needs health plan owned by community-based organizations designed for persons living with HIV, AIDS in Manhattan, Brooklyn, and the Bronx. In 2004, one of the earliest organizations to obtain rapid testing waiver, allowing clients to access immediate results and a faster connection to care. In 2006, the first and only Spanish language ADHC was created to address the rapidly growing Latino population affected by HIV and AIDS, called El Faro, or otherwise the Lighthouse. In 2007, we formed a partnership and then later acquired the Foundation for Research on Sexually Transmitted Diseases, which is called Frosted D. This was done to give chronic substance users, HIV positive, formerly homeless person, and YMSMS2 access to health care. Specifically, this allowed us to build out our harm reduction services, including syringe exchange to provide recovery support services to our clients living with addiction, and to offer 2 housing facilities for those in immediate need of shelter. Also in 2007, we were awarded a federally qualified healthcare center grant to serve the homeless. This designation allowed Harlem United with the opportunity to provide homeless persons with health care services that would otherwise not be accessible. In 2008, our housing program expanded to include the first of 2 permanent congregate housing facilities, Foundation House West, followed in 2011 by Foundation House East, giving us a total of 586 units of supportive housing. We begin to shift the model. By the end of 2010, Harlem United began to understand the role of prevention as treatment, and we focused on expanding that area in our services. In 2011, we integrated a rapid hepatitis C screening into our testing program with a connection to care for those persons found to be positive. Additionally, access to care within our prevention division was created in order to link persons to care, increasing re-engagement efforts to high-risk homeless and HIV in persons. In 2012, a care management service model, Health Home, was introduced, whereby the caregiver of a person, okay. In 2012, a care management service model, Health Home, was introduced, giving the caregiver of a client communication with one another, ensuring their needs are addressed in a comprehensive manner. In 2014, Harlem United has continued to reinvent itself in order to continue to meet the ever-changing needs of our clients, as we have been able to add more services in response to the needs of our persons. We are now serving persons with multiple chronic diseases beyond HIV and AIDS, focusing on those who are homeless and are suffering from mental health or substance use disorders, or social stigma related to their sexuality, gender, or HIV status. Harlem United remains the last resort for medically underserviced communities of color in Harlem. In 2015, we were able to open a clinic, which allowed us to expand our services to the entire community. We continue to build our team based healthcare delivery model led by physicians to provide comprehensive medical care with the end goal of maximizing health outcomes. I also wanted to share that throughout all our Harlem United programs, we utilize the approach of addressing each person by providing updated information access to nutrition responsibilities for those with food insecurities, continue to address symptoms developed during the pandemic, such as mental health struggles, increased substance use disorder, and feelings of isolation. HU works from the perspective of diversity, cultural competence, being a crucial aspect of providing excellent care. HU has increased the number of male doctors of color, because that we noticed that was a barrier for our community members to get service. Not being able to see doctors that understood their culture or understood, their struggles. At the new clinic that I was telling you about, we offer primary care, cardiology, GYN services, dental service, mental health services, HIV care and prevention, substance use disorder. We also have a facility that offer integrated harm reduction services. And of course, my favorite, the ADHD program. Here we offer nutrition groups, we offer nursing and wellness, we offer clinical support groups to address trauma-informed care needs. We offer services to address spiritual needs. We have a pastoral counselor on site who runs group and who also have we call it spiritual reflections, where she put time aside for an individual who needs to come speak to her about them dealing with their lifestyle and their beliefs. So we found that is really a big barrier for clients to come get service, because if they feel like, if they have the opinion of, okay, I'm going here for services, but I'm not being able to feed my spiritual side. So we implemented services for that. Short but sweet. I'm done. Any questions? Please feel free to put it in the chat. I want to thank you for giving me the opportunity to speak on the panel, and thank you.
Thank you, Margot, and thank you, everyone. Anthony, and for all these great presentations. We really appreciate all your support. If you have any question for our panelists, please make sure that you type your question in either the chat box or the Q&A feature. In the meantime, please make sure that after the webinar, you complete the post survey. And if you have any questions, or if you would like to ask questions and you are not right now with the time to do it, please feel free to submit your questions as well. We're going to make sure that either Jamie, Margot, and Anthony can answer your questions. But Fide, any questions?
Hi. Yes, we did have some questions, but they were already answered in the chat.
Excellent. So on behalf of the National Center for Health and Public Housing, I want to thank our panelists and thank you for everything you're doing in your communities to address this important issue. And I am quite sure that the audience is also working on their particular communities and making sure that they address all the needs of patients with HIV. And if you have any additional questions, please feel free to submit the questions. And or you can also contact our staff members, and we are going to be honored and happy to assist you. Thank you so much for attending this webinar, and happy holidays. Have a great afternoon.
Take care. Thank you, everyone.
Thank you.